Now coming to the complications of cataract surgery, complications of the surgery. They could be pre-op complication, intra-op complication, post-op complication. Pre-operative complication means now the surgery haven't started, but still some complications can occur. Why? Why? Pre-op are the anesthetist complication or anesthetic complication. Pre-op complication are the anesthetic complication. The anesthetic complication can be coming in 3 routes. Why? Because anesthesia to the eye is given by 3 routes. What are the 3 routes by which you give anesthesia to the eye? The retrobulbar route, peribulbar route and the topical route. So the complications of in pre-op also come by 3 routes. First is what, guys? Retrobulbar complication. What do you see in the retrobulbar complication? Okay? In retrobulbar complication means what? You give anesthesia to the eye by retrobulbar, peribulbar or topical. And you take a needle, put the needle beneath the eyeball, aim towards the cone of the muscle and then inject the local anesthetic drug. Okay? So while injecting, what complications could occur? While injecting, if you are a new anesthetist or a new ophthalmologist, what can happen, guys? You can easily rupture the globe. You can easily rupture the eyeball. So a rupture of the eyeball, or you can easily damage the blood vessels over there, which can cause what? Retrobulbar hemorrhage. Okay? You can cause globe rupture, retrobulbar hemorrhage. So retrobulbar complications. We are discussing about the complications of the cataract surgery. Pre-op, intra-op, post-op. The preoperative complications are the anesthetic complications. Anesthesia is given by retrobulbar, peribulbar and topical route. So the retrobulbar complications are, while giving anesthesia to the eye by retrobulbar route, the patient might develop retrobulbar hemorrhage, globe perforation, or sometimes if accidentally you inject the local anesthetic into the you give an intrathecal injection, then what will happen? It becomes lethal. So intrathecal injection can cause death of the patient also. Intrathecal injection can cause death of the patient. So that is regarding what, guys? That's regarding the complication, retrobulbar hemorrhage, globe perforation and intrathecal injection. Next is what? Peribulbar. If you give anesthesia to the eye by peribulbar route, then what could happen, guys? If you give anesthesia to the eye by peribulbar route, again you can cause damage to the globe. Globe rupture or globe perforation can happen. If you give anesthesia to the eye by topical routes, first of all you need to remember, topical means you are using a local anesthetic topically. Remember, if you are using a local anesthetic topically on the, you are putting the eye drops, then what will happen? It will just cause surface anesthesia. The ocular movements will be intact. This topical route of giving anesthesia is usually beneficial for what patients? The literate patients who will listen to you. Okay? If the patient is illiterate, if he is not listening, never go for topical anesthesia. Why? Because topical is only suitable for the persons who listen to you. Who listen to you means what? Who understands the thing and all. I'm not telling that all the illiterate people are not understanding the thing. They will also understand. But the literate individuals, they will understand, they will respond to you, they will follow your commands and all. Okay? So remember, guys, topical, you can use eye drops. It can be given in educated patient or cooperative patient, but not in children. So remember, the complications of cataract surgery are pre-op complications where they are just anesthetic complication, retrobulbar, peribulbar or topical. Next is what? Intra-op complications. And during surgery, what complications you might encounter? During surgery, as you are doing the surgery, what complications you can see? You can, while doing the surgery, you can damage the anterior capsule, damage to the capsule. You can cause damage to the iris. It can lead to iris rupture. Okay? You can easily damage the things. During surgery, what are the complications you might, we'll start from here. Intraop complications, guys. Intraop complications means during surgery, what can happen? During surgery, you might damage the things which are there, such as you might damage the iris, okay? You might damage the cornea. As you are damaging the iris or the cornea, cornea is avascular, but if you damage the iris, the blood vessels are near the iris. If they damage, you will see blood getting collected in the anterior chamber, which is called as hyphema. And during surgery, you might also see there is a rupture of the capsule, right? So intraoperative complications that could be seen in cataract is what, guys? Intraoperative complication is rupture. What rupture? Iris rupture could occur, corneal rupture could occur, the capsule rupture. Normally you will rupture. Sometimes what happens? You take an incision on the anterior capsule, remove the lens, but while taking an incision, the posterior capsule is also ruptured. Sometimes due to the posterior capsule, sometimes you might go into the posterior segment, that leads to vitreous loss also. So vitreous loss could occur, posterior capsular rupture could occur, iris rupture could occur, corneal rupture could occur, blood in the anterior chamber. Collection of blood in the anterior chamber is called as what? Hyphema. This all could occur as intraoperative complications. All these are what complications, guys? Intraoperative complications. Coming to the last, which is called as postoperative complications. Postoperative complications. Yani ke after cataract surgery, what are the complications you see in the patient? So after cataract surgery, guys, what are the complications that you see in the patient? What do you see, guys, after cataract surgery? There are many complications. One complication is called as after cataract only. Now, what is this after cataract? There are many complications. One is after cataract, one is endophthalmitis, one is slow painless loss of vision, sudden painless loss of vision, slow painful, sudden painful. What is this, guys? Other is aphakia. Many complications are there. Just look over here. What is this? Remember, post-op complications, what we are discussing, 90% of the patients after doing the cataract surgery, they will develop cataract once again. Why? Why? Because some remnants of the opacified lens that you have removed, those remnants were there. When you place a normal intraocular lens after cataract surgery, those remnants goes towards the new intraocular lens, and that can cause what? Cataract. Cataract developing after cataract surgery is called as what? After cataract. It is called as what, guys? After cataract. So 90% of the patients develops after cataract. After cataract. After cataract. Just look over here, guys. After cataract. You can just write there. What is after cataract? After cataract is a post-op complication. After cataract is a post-op complication. Meaning what? Cataract developing after cataract surgery. Cataract developing after what surgery? After cataract surgery is called as after cataract. Okay? Cataract developing after cataract surgery is called as after cataract, right? Younger the patient, faster is the occurrence. Now guys, look over here. In after cataract, what do you see? So basically, imagine you have done the surgery and the patient has gone to his home and the patient is very happy and all. And after few days, the patient comes back to you and tells the doctor, I'm having polyopia, I'm having xanthopsia, I'm having same features of cataract. Now you will be worried, why is he having these features? Make the patient sit in the slit lamp examination. Examine his eye. Now while examining his eye, what will you see? You will see some pearl-like things developing on the lens. That is called as Elching pearls. Or you might see a ring developing near the lens, which is called as Sommering rings. If you see these two things are the features, classical features of what? After cataract. Right? So it is the fastest and the most common complication among all post-op complication, which is also called as after cataract. Okay? Now after cataract, what do you see over here? Elching pearls and Sommering rings. Elching pearls, or you will see ring like over here. Ring. Okay? Sommering ring. Elching pearl is pearl-like cluster formed from the growth of epithelial cells. Yani basically, you will see a pearl-like crystals developing on the capsule of the lens. That is called as elching pearls. Or you might see a donut shape remnant on the lens. Donut shape remnant on the lens. So two things which are very, very important, guys, that you see over here is what? Elching pearls and sommering rings, which are seen in after cataract. So guys, if a person comes with after cataract, what will you do now? What will you do now? For treatment of the patient who's coming with after cataract, what will you do? You do a capsulotomy. Again, you don't go for the surgery. What you will do? That's a new lens you have already placed. You will see some remnants of the lens fibers, that is elching pearls and sommering rings. You can go for a small incisional surgery or micro incisional surgery. You give a small incision on the capsule, open the capsule. Now you will be looking at the intraocular lens. Now what will you do? Now you take a laser called as Nd:YAG laser. Nd:YAG full form is Nd is neodymium, Y is yttrium, A is aluminium, G is garnet. You take this Nd:YAG laser, and with this Nd:YAG laser, remove the elching pearls and sommering rings. That is the main management of what? After cataract. So remember, guys, so we do capsulotomy with Nd:YAG laser. The wavelength of this laser is 1064 nm. Okay? In which Nd stands for what? What is Nd:YAG? Nd stands for neodymium. Y stands for yttrium. A stands for aluminium. And G stands for garnet. Okay? Neodymium, yttrium, aluminium and garnet. Nd:YAG is a colorless laser. Nd:YAG is what laser, guys? It's a colorless laser. It is used for what surgery? It is used for after cataract. So cataract developing after cataract surgery is called as after cataract. Okay. Now guys, that is, we are discussing about the post-op complication. Remember guys, we have discussed about the pre-op complications where what? It were anesthetic complications. Pre-op were the anesthetic complications. Then there was intra-op complications. Intra-op complications were rupture of the iris, rupture of the capsule, rupture of the cornea, hyphema and all. Then there is post-op complication. Post-op means after surgery. After surgery, you will see after cataract. And after cataract, apart from that, one of the complications is after cataract. Sometimes after surgery, remember, sometimes after surgery, if you touch the sometimes after surgery, the patient might develop edema of the macula in a cystic-like fashion, which is called as cystoid macular edema. The next common complication that can occur after cataract surgery is what, guys? Cystoid macular edema. The macula is there, no? The macula becomes edematous after surgery. Any macular edema occurring after cataract surgery is called as Irvine gas syndrome. It's called as what, guys? Irvine gas syndrome, right? So this is regarding the next complication. Next is what? Sometimes the patient might have what? Sudden painless loss of vision or sudden painful loss of vision. Remember guys, if the patient complains of sudden painless loss of vision, what are the other things that we need to rule out? Sudden painless loss of vision can be seen in vitreous hemorrhage, retinal detachment and intraocular dislocation. Sudden painless, yani ki patient does not have pain. Sudden painless loss of vision, the most common cause of this is cataract. Okay? Apart from, remember, we are discussing still the complications, guys. Next is sudden painless loss of vision. Sudden painless loss of vision can occur after cataract surgery. But what are the other causes of sudden painless loss of vision? Vitreous hemorrhage, retinal detachment and intraocular lens dislocation. Sometimes the patient might complain of sudden painful loss of vision, okay, after cataract surgery. What are the other causes? Uveitis and endophthalmitis can also be the cause of sudden painful loss of vision, right? Now coming to the most dreadful complication of cataract surgery. What is the most dreadful complication of cataract surgery, guys? The most dreadful complication of cataract surgery is endophthalmitis. Endophthalmitis. We are discussing about the post-op complications. After cataract is one complication. Cystoid macular edema is other complication. Sudden painless loss of vision is one complication. Sudden painful loss of vision is other complication. Now we are discussing about the most dreadful complication of cataract surgery, which is what, guys? Which is called as endophthalmitis. We are coming to the most dreadful complication of cataract surgery, which is called as what, guys? Endophthalmitis. This endophthalmitis occurs when the cataract surgery is done in an unhygienic manner. When you don't do the surgery hygienically, the patient will develop this complication called as endophthalmitis. I have seen a surgeon, I have seen some surgeons who, in order to create a record and all, they did many surgeries in a day. But in the process of creating a record, what happened? Unhygienically, they perform the surgery. When unhygienically you perform the surgery, unhygienically meaning what? It's not intentional. It will be unintentional only. Okay? When you want to create a record, you will do surgery. Like there was a surgeon who did multiple surgeries on a single day. But if you do multiple surgeries, you require multiple instrumentation. That much of instrumentation and all, sterile instrumentation was not available. He was using the same instrument on the patients. So what happened? An organism called as Staph aureus entered the eye, led to what? Endophthalmitis. Endophthalmitis, right? If endophthalmitis infection goes to the sclera, then it becomes panophthalmitis. But remember, we are discussing about what? Endophthalmitis, which is the most dreadful complication of cataract surgery. It is a most dreadful complication of cataract surgery. Endophthalmitis is the most dreadful complication of cataract surgery. Right? Why it is seen? If the surgery is done in an unhygienic manner. It is seen if the surgery is done in unhygienic manner. If the surgery is done in an unhygienic manner, you will see this endophthalmitis. I told you what's the most common organism. The most common organism is Staph aureus. It is Staph aureus. Staph aureus is the most common organism. Okay. If endophthalmitis occurs after 7 days of surgery, if endophthalmitis, remember, if it occurs within 7 days, it is Staph aureus. If it is occurring after 7 days, then the causative organism is what? Propionibacterium acne. Propionibacterium. Okay, just cut this point. We won't be writing this point. Cut this point. Right. So, the most common, we'll start from here. The most common organism over here is Staph aureus. Staph aureus is the most common causative organism. What is the clinical feature, guys? What is the clinical feature? The clinical feature is what? The patient complains of sudden painful loss of vision. Sudden painful loss of vision. Right? When this patient comes to you, you examine his eye. What you will see? You will see pus in the vitreous humor. Right? So what will you do, guys? How will you approach a patient who's suffering with endophthalmitis? You can first remove some pus by doing pars plana vitrectomy. Okay? Why? Because it's in the vitreous humor. You can just remove the pus by doing pars plana vitrectomy. Or if there is a little bit of pus, you can give an injection of amikacin, intravitreal injection of amikacin. So remember, guys, for diagnosis, you will see pus in the vitreous humor, right? To prevent this, what are we doing nowadays? To prevent this, we are giving intravitreal injection of amikacin. If there is small pus, remember, guys, for prevention also we are giving this, and for the management also we give this injection of amikacin intravitreal. But if the pus is much then what will you do? You have to remove the pus by pars plana vitrectomy. We remove the pus. We remove the pus by pars plana vitrectomy. That is regarding what, guys? That's regarding endophthalmitis. That's regarding what? Endophthalmitis, right? Coming to the next complication of cataract surgery, which is called as aphakia. Nowadays, it is not seen, guys. Aphakia is absence of lens. But why are we seeing nowadays? We don't see it nowadays. Aphakia was seen when ICCE was done. In ICCE, we were removing the lens as well as capsule. Whereas nowadays, there is no aphakia. But if at all aphakia is seen, what will you see? Aphakic patient will complain of what? They will complain of diplopia. They will complain of scotoma. Scotoma is what, guys? Localized loss of vision surrounded by a good normal vision. That is called as scotoma. Patient complains of jack-in-the-box scotoma or pin cushion defect. Remember, nowadays, first of all, it is not at all seen. That's why I am not at all emphasizing on it. Aphakia is a complication that is seen after ICCE. If the patient becomes aphakic, the patient will have diplopia, pin cushion defect and scotoma. What scotoma? Jack-in-the-box or roving ring scotoma. Now guys, what is this pin cushion defect? Pin cushion defect meaning what? Any aphakic patient, you tell him to look at the straight wall, he'll tell what? The wall is big, wall is appearing like a cushion, or wall is appearing to him like a cave. Okay? So remember, pin cushion defect meaning what? Aphakia. Aphakia nowadays, we'll start from here. Aphakia nowadays is not seen as a complication. Aphakia was seen after ICCE. The main complaint of the patient of aphakia is what? If the patient complains of aphakia, the patient who is without lens, he can't do accommodation. He'll have diplopia. He'll have scotomic vision. Scotomic vision meaning what? Scotoma is localized loss of vision surrounded by a good peripheral vision. A blind spot appearing in the visual field is called as scotoma. Okay? That scotoma is called as roving ring scotoma or jack-in-the-box scotoma. Patient will also complain of pin cushion defect. What is that pin cushion defect? If you tell the patient to look at the wall, he'll tell that the wall is bit curved. Everything appears to him as a curve. That is called as pin cushion defect. But again, guys, aphakia is not that important complication. Okay. So I have already told you, patient of aphakia will have diplopia, scotoma, pin cushion defect, and treatment of aphakia is what, guys? It's very simple. The treatment of aphakia is what? Treatment is simple, guys. If the patient is without lens, the treatment is what? You go for placing an IOL. The best is PC-IOL. The best is PC-IOL. Okay? But in some patient, if the posterior capsule is ruptured, imagine the patient had posterior capsular cataract and the posterior capsule is ruptured, then you can go for AC-IOL. But this AC-IOL is having some complications. Okay? So remember, the best treatment of choice for aphakia is what? IOL placement. What is IOL placement? Intraocular lens placement. That is the best treatment. Which intraocular lens? PC-IOL. What is PC-IOL? Posterior capsular intraocular lens. But if posterior capsule is ruptured, then you can go for AC-IOL. But AC-IOL, anterior capsular IOL, it comes with a complication of UGH syndrome. What is UGH? Uveitis, glaucoma and hyphema syndrome. Right? Uveitis, glaucoma and hyphema syndrome. So remember, guys, for aphakia, the treatment of choice is IOL. That is PC-IOL. AC-IOL can be done if posterior capsule is ruptured. Okay? AC-IOL ke what is the complications? UGH syndrome, uveitis, glaucoma and hyphema, right? So this is regarding what, guys? This is regarding the aphakia. Aphakia, the best option is what, guys? The best option is PC-IOL. But if posterior capsule is ruptured, then AC-IOL. Okay? If problem persists after using contact lenses, then we need, remember, guys, for aphakic patients, we can also give contact lenses. But again, that contact lenses and glasses are not the best one. The best option is what, guys? For aphakia, it is IOL placement. IOL placement. Best is PCIOL. If PCIOL is not there, we can go for ACIOL. We can go for ACIOL. But if PC and AC both are not there, if IOL is not there, then you go for contact lenses. If contact lenses still doesn't work, then you can go for glasses and all. Okay? Right. Then you can go for glasses. That's regarding what? That's regarding the aphakia. So remember guys, I told you one thing. Before placing an IOL, we have to check the power of the eye. For checking the power of the eye, the instrument that we use is called as biometry. Biometry measures two things. What two things we measure with biometry? We measure the axial length and we measure the keratometry. In biometry, we measure the axial length and keratometry. We take these two readings and put in a formula which is called as SRK formula. It's not Shah Rukh Khan formula. It is what? Sanders-Retzlaff-Kraft formula. Sanders-Retzlaff-Kraft formula. We keep this reading in this formula and we check the power of the intraocular lens. So remember guys, before placing an IOL, the best investigation, two investigations, again this is an MCQ, which is done is what guys? Axial length and keratometry. Come on guys, what is the axial length of the eyeball? Axial length of the eyeball. The normal axial length of the eyeball is 24 mm. At birth it is 16.5 mm. Keratometry measures what? Curvature of the cornea. Okay. That's regarding what guys? That's regarding the cataract surgery. Now coming to pediatric cataract. For pediatric cataract, the timing is very, very important. Rather than the surgery, the timing is important. What surgery is done and all. Why? Because for pediatric cataract, neither you go for ICC or ECC and all. Pediatric cataract, we just give an incision on the capsule, either the anterior or the posterior, which one is easily accessible. Why? Because it will be very difficult to access the capsule and all. So anterior capsulotomy you can go for, or posterior capsulotomy, you can remove the lens and then place the IOL. Okay? But remember guys, remember the timing is very important. Timing means what? If the patient is coming with unilateral cataract, the timing is different, and if the patient is coming with bilateral cataract, then the timing is different. Now guys, unilateral cataract, it is always said that if the child is being diagnosed with unilateral cataract, operate the child immediately. Operate the child immediately. If the child is having bilateral cataract, you will be having 2 to 4 months. Yani operate the child before 2 to 4 months of age. Operate the child before 2 to 4 months of age. Why? Why unilateral? You have to go immediate management. Why? Because unilateral cataract means one eye the child is having cataract, other eye is normal. As the child is born with a cataract in one eye, other eye is normal. What happens? He is now slowly learning for foveal fixation. As he is learning foveal fixation, this eye learns foveal fixation. And what happens guys? What happens? As this eye has not learned foveal fixation, you guys know what is foveal fixation? Learning the things, learning, basically it is the learning habit of the retina to focus the light rays on it. Okay? Remember, left eye, this eye has learned the habit, but this eye is not learned. Why? Because there is an opaque lens that is not allowing the light rays to focus on the retina. So what happens? The pressure on this eye increases. The pressure on the normal eye increases, right? This eye will develop normal, this cataract eye will have poor vision, but as the pressure is increased on this other eye, that eye will also slowly develop poor vision. That is called as amblyopia. In unilateral cataract cases, the normal eye, the chances of normal eye to develop amblyopia is very high. That's why what we do guys, that's why what we do for unilateral cataract surgery, we have to operate immediately so that the other eye doesn't develop amblyopia. Whereas for bilateral you are having some time. You are having some time. If the child is having bilateral congenital cataract, you can take some time. Why? Because both the eyes will not develop foveal fixation. There is no risk of amblyopia. But before 2 to 4 months, you have to operate the child. Why? Because he has to learn the habit of foveal fixation. Yes or no? So the chance of amblyopia or lazy eye, amblyopia is a lazy eye, and a patient will develop poor vision due to that amblyopia. The chances of amblyopia is very high in unilateral cataract, whereas the chances of amblyopia is low in bilateral cataract. Hence, for bilateral cataract, you can wait for 2 to 4 months. Okay. So remember guys, for unilateral cataract, operate the child immediately. For bilateral cataract, you can operate the child before 2 to 4 months of age, and before foveal fixation. Before foveal fixation. Why unilateral you are operating immediately? Why? Because unilateral patients, unilateral cataract patients develop amblyopia easily. They develop amblyopia very easily. Unilateral cataract patient develops amblyopia very easily, right? Next. What is amblyopia, guys? What is amblyopia? Amblyopia is loss of vision with unknown cause. Amblyopia is loss of vision with unknown cause. Okay. It can usually occur before 8 years of age and all. So basically remember, unilateral patients are at higher risk of amblyopia. That's why we are operating them immediately. This was an MCQ. Okay. Now guys, remember, what is the surgery done? Can you go for the ICCE? Never sir. ICCE is only done for subluxation and dislocation. Can you go for ECCE? It can be done sir, but this ECCE is having some complication called as after cataract. The child cannot withstand after cataract. In children, there is no procedure, there is no one procedure name given. In children, either we can go for anterior capsulotomy or posterior capsulotomy. In children, we usually look for the viability, which we usually look for what is easy for us. Okay, we can either go for anterior capsulotomy or posterior capsulotomy. Then we remove the lens and then we place an IOL. But before placing an intraocular lens, what is the investigation done? Axial length and keratometry. Can you do this biometry for a baby who is like 7 months old and 8 months old? No. Biometry is very difficult for that age. So what we do? We remove the lens. After removing the lens, we wait for the child to become 2 years old. Once the child becomes 2 years old, then we go for biometry, where we measure the axial length and keratometry, where we measure the exact power of the intraocular lens, and then we place it. Why? Because pediatric eye is growing every day. So at least the child should be 2 years, so that you can calculate the power of the eye. Then after calculating the power of the eye, power of the lens, then you can place an IOL. That kind of IOL that is placed after the child becomes 2 years is called as secondary IOL. It's called as secondary IOL. Okay. So remember guys, in pediatric cases, what we do guys, ICCE is not done. ECCE is also not done. Phacoemulsification can be done in older children. In pediatric cases, we go for either anterior capsulotomy or either we go for posterior capsulotomy. Then we go for lensectomy and placement of the IOL. In children, we put the PC IOL, that too after 2 years of age. As the pediatric eye is growing, it is very difficult to calculate the exact intraocular lens power, right? So this IOL should be placed after how many years guys? 2 years only, after 2 years. And whenever you are placing an IOL in the pediatric age group, remember pediatrics are almost, all children are hypermetropic. Always undercorrect the IOL and place it. Hypermetropics are undercorrected, myopics are overcorrected. Okay. So remember guys, whenever IOL is put in a child, it is always undercorrected. Why? Because the children are hypermetropic. The children are what guys? Hypermetropic. We'll discuss what is undercorrection and overcorrection while discussing the optics and refraction. So remember guys, this was regarding the pediatric cataract. If it is unilateral cataract, operate immediately. If it is a bilateral cataract, you can operate before 2 to 4 months of age. Okay. So that's regarding the cataract guys. Okay. Thank you.